So let me just share my screen. Right. I hope everyone can see the presentation slide.
Yes, you can go ahead.
Do you want me to start, sir?
Yeah, you can go ahead, sir.
Okay. Thank you, the organizers, for having me on here for the second session. And till now, what we have been discussing about is the treatment for salivary gland stones and how the treatment has undergone a paradigm shift from when we used to prefer a gland excision to now a minimally access techniques. So today, this will be my topic. And just on the outset, we've all seen this kind of a picture in our day-to-day practice. There's the gentleman with a right-sided parotid gland swelling, which of course has pain associated with it, which is exacerbated during meals. And on examination, we might find pus discharge from the parotid duct opening. Now, how would you proceed with this kind of a clinical picture? Of course, you would give the supportive therapy for acute sialendoscopy. First, that remains the forefront, which constitutes of our antibiotics, our analgesics, our fermentation, massages, and everything. And with this picture, we also on our palpation, we find quite firm gland. So sometimes, our mind goes towards thinking maybe it's a tumor which has gotten infected. So we usually, our first line of investigation would be contrast enhanced computerized tomography, as well as an FNAC. And then, of course, since we are thinking of intervention, we get our routine blood investigations. Now, let's say our answers come up like this. A CCT scan shows just gland inflammation or a bulky gland with no sign of any obstruction. There are no cyanolytes, there's nothing. There is nothing which looks like a homogeneous or a heterogeneous tumor on the CECT. The FNAC, maybe if it was done ultrasound or whatever, it comes out as chronic sialendinitis. We are basically then left blank. How to proceed with this patient further? So many a times we would revert back to a supportive therapy. We would withdraw the antibiotics. We would ask the patient to just massage, and hopefully this condition would be self-limiting and resolving. But it's always not always the case. So just to reiterate, the most readily identifiable obstructive etiology remains sialolithiasis, with the incidences that we all know about. Now, when we were to label the rest of the cases in the past, it was basically chronic sialendinitis of unknown origin, and we would just leave it at that. It's only in the late 1980s that the ultrasonologists really got geared up, and they would really see the ducts, especially the parotid gland, which was more common. And then they would try these minimally invasive techniques like just putting an ultrasound guided balloon through the papilla and just hoping to dilate some strictures that they would catch on the ultrasound. However, with the advent of the endoscope in the 1990s, now since we are able to get inside the duct and really see what's going on, what's causing the obstruction, now these have been further classified according to stenosis, kinks, foreign bodies, ductal inflammation, which is called sialendoscopitis, and further and so on. Now, with these different modalities comes the new era of treatment as well, where we have a myriad of treatment strategies to tackle these conditions. So, clinical examination, this is just a repetition from the last, continuation from the last lecture, that the clinical examination really doesn't change. We still try to rule out stones in such patients. And palpation remains paramount. And examination of the salivary papilla is very, very important, especially in stenosis patients, because sometimes you have a stenosis of the papilla itself, and you see no saliva expression on gland massage. When it comes to radiology, these were the complete list of investigations that we had in our armamentarium. However, once we know we are not dealing with something with sialolithiasis, The OPG and the CBCT has no role whatsoever. Of course, the X-ray sialography does depict stenosis and the other maladies quite well. However, it has largely fallen out of favor because of the ductal inflammation that the radiopaque dye can cause. And of course, once you subject the patient to a sialography, you cannot really do a treatment for the next week or 10 days. MR sialography has emerged uh, because of all the shortcomings which are there with the conventional sialography. And I shall be going into more detail about that later. Now, this is an image of a per technate scan. And this is really, really salivary gland function tool, wherein, with your level of intensity of your uptake, that tells you just how much the gland is functioning, and this will have a really, really important effect on my talk later, and it influences all our results. This is not something that we usually do. We reserve it for basically our failures, but yes, this, I want you to just remember this image. Of course, we have the ultrasound, which in Europe is all the vogue, and that's basically all they do. And they, as a consequence, have become very, very good at catching even minor abnormalities of the duct. So, getting into more detail, just a historical perspective, the conventional sialography is an excellent visualization tool of your duct. In the first image, we can see a stricture which is mid-ductal in origin of the submandibular duct. You can see this, if you can see my cursor, that's the introducer where the dye is being introduced into the papilla, and we see a normal duct right till almost the prehilar region, and we'll see a non-uptake of your contrast right there. And then, of course, you have scattered elements of your contrast going towards the gland. The pitfalls of this technique is, of course, one, it's invasive. Second, your radiopaque dye can cause ductal inflammation and cause problems of its own. Number three, we cannot really put in an endoscope to correct this abnormality till all the dye has been washed out, which is usually about 7 to 10 days. But there's also high incidence of radiation exposure to the patient, because you really need to take multiple radiographs to accurately see the entire length of the duct. And these are basically the digitally remastered photographs that we have seen right here. The ultrasound throughout Europe and in very, very experienced hands, it is the gold standard in my opinion. And amongst everyone, it has emerged as a screening investigation of choice, because the dense strictures, your dilated ducts, as you can see on the image right here, this blackish thing is the duct, and there you see a stricture right behind it, and you see the duct which is quite dilated. So the ultrasound, the basic rule of thumb is, whenever you have a dilatation, you should always look for an obstruction right distal to it. So it also gives excellent delineation about the gland as well. So you rule out your tumors that way. It is, of course, low cost, repeatable, and it's a valuable intraoperative tool as well. However, it is operator dependent, and there's a lot of specialized training which needs to go into it before you can really, really make your um, diagnosis solely on the basis of ultrasound. So at the end of the day, we basically, forgive the pun, we try to leave no stone unturned in trying to find a pathology, but there are still issues with what to do if you don't find anything. So, possible causes of obstruction after the entire array of tests, these are the possibilities that you can come across. So, let's remove sialolithiasis from right here. So, we have a stenosis, ductal dilatation, kinks, foreign bodies, and sometimes just a non-specific finding of an altered gland ecotexture. So, when we come to the possible causes of identifiable stenosis, we know there are some systemic conditions which are related to this condition. The most common being the Sjögren syndrome, which is what is taught in our post graduation, and it's a very common syndrome which primarily attacks salivary glands and ducts. There is another entity called the juvenile recurrent parotitis, which is a self-limiting condition of especially the parotid duct, and seen in adolescent children. In this, there are multiple attacks of parotitis throughout the year requiring antibiotics and supportive therapy. And we shall see what the duct looks like in these patients later. But before the advent of Sialendoscopy, we really didn't know what to do, and we would just give supportive management or antibiotics over and over again. We all know about the post radiotherapy patients, and I would really like to point out the radioiodine therapy. We all know that for thyroid malignancies, when we give radioiodine, it preferably uptakes in the salivary glands, and it gets excreted from the ducts very, very slowly, leaving its ductal inflammation scars on the duct, which leads to recurrent sialadenitis as well. We have the IgG4 related disorders, which are primarily ductal and glandular, and we have viral etiologies. Now, apart from all these, and these can sometimes, be diagnosed on the basis of our history, on the basis of our serologies. We have our idiopathic causes as well, where we don't know what's causing the problem, but we just know that there is a problem. So when we come to our lab investigations, we had our routine blood test, which we got done earlier. But now we include this array of serology to try and find out a systemic cause, if there is any. And the last point, which is skeletal X-ray and the cephalometry, is something that I want to point out. And this is not one of the first line investigation, but this is invaluable in some conditions, which I shall be discussing in a bit. So coming back to MRI sialography. Now, what is MRI sialography? It's basically, we use the same software which is present in any 3 Tesla MRI machine. It is just heavily T2 weighted stirred images. With the heavily T2 weighted images, all stationary fluids appear as whitish. Now, that is used in a very great way because the saliva being stationary within the ducts helps to delineate the ducts really, really well. In the picture on the right, we can see the the left parotid duct, which is quite dilated, and when you go towards the gland, you have a punctate stricture right here. And this really, really is an excellent spatial orientation tool as well, and you can really measure your length of stenosis and everything. In addition, you also get information about your surrounding inflammation or um, problems or compressing tumors which are present extraductally. And it is virtually pathognomic in Sjogren's and HIV sialidinosis. Now, additionally, it is invaluable in diagnosing papillary stenosis. In papillary stenosis, there's no other investigation which can be considered as the first line because the conventional sialography, if you can't get inside the papilla, you can't really conduct the investigation. CT is useless. Ultrasound, when you come to the distal segment of the duct, it's not really, really that reliable unless you're putting a probe right on where the papilla should be and you hope to catch something. Now, once we got all our radiology, we had to classify what we were dealing with. And once we and Francis Marshall in Geneva came up with this excellent, um, sorry, classification tool in which the stenosis of the duct was divided anatomically. Now, remember this classification came out almost 17, 18 years back. Now, he divided into S1, S2, S3, and S4 according to the type of stenosis. S1 stricture is basically, if you can see the first image, is just a punctate fibrous strand with not really any major implication on the salivary duct. Now, once you have such a short band, it becomes really, really quite easily managed with your endoscopies. When we come to an S2 stricture, S2 stricture is an elongated segment of the duct which has undergone stenosis or narrowing, right? When the entire main duct is involved, that's called an S3. And when the entire main duct along with the peripheral branches are involved, that's the S4. So indirectly, what was really considered was, your S1 and your S2 strictures were considered the easy strictures, which wherein your endoscopy could really prove to be quite fruitful. However, your S3 and S4 were the ones which were always going to create problems later on. So the counseling really became slightly easier when it over the years, where we were using some kind of a classification. Now I'm just going to I want to dissect this classification further. So if just give me a minute, I'm just going to skip just a second. Okay, so back to the drawing board. Forgive me. So just talking about an S3 strictures. Now we are talking about the pitfalls of the classification that we just saw, right? Now imagine that this is the main duct and you have your peripheral branches going from here, right? Now your S1 stricture is basically a punctate stricture which can happen anywhere from here, 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 or here. However, and let's say this is our distal end and this is our proximal end, obviously. Now, suppose a stricture is happening here, your S1 stricture, and the patient is symptomatic, even though it's just one branch. Your prognosis is going to get worse and worse as you go proximally because there are issues like your length of your endoscope, your angulation of your branch, and your stent actually reaching till the stricture to prevent any future recurrence. Whereas if the punctate stricture is right here, we know that we'll be able to manage quite well with our endoscope because and our stent at the end of the procedure can really bypass the stricture at the end of the procedure. We keep it for a prolonged period and we know that the patient is fine. So it was a very good anatomical tool, but nothing really told us about the prognostication of the case. Similarly, for the S2 strictures as well, a distal S2 stricture is always going to be uh, easily or better managed than a proximal S2 stricture, right? So this really did not tell us too much about how we should prognosticate and counsel our patients. And that was the major problem with with this classification. In 2017, Michael Koch and Heinrich Iro in the Erlangen Institute, they came up with a new classification when they divided number one, the strictures according to tissue appearance. So they could be inflammatory, they could be a web, or they could be fibrous strictures. Now imagine this is more likely represents a continuum of a spectrum of your stricture formation. Initially, it is inflammatory, so these are very easily correctable and they really don't recur if you've done a good enough job. Fibrous strictures are something which can happen over and over again, similar to, let's say, a tracheal dilatation where you have a tense stricture. Whatever you do, a balloon or this thing, the thing would really works at the end is an end-to-end anastomosis. Your second criteria was your location. So we have a papilla, distal, middle, and a proximal duct. So as you go proximal, the lower are your chances of completely curing the patient. Your grade of stenosis is similar to your tracheal stenosis again. However, we've tried to delineate it with a size of endoscopes. And this again, in complete or filiform strictures, you really can't dilate that much because endoscope is your endoscope is basically just going to have its own limitations. Your length of strictures was the next, and your number and your side. So this entire classification really, really looked at the treatment-oriented aspect of the stenosis. And because you know what kind of stricture that you're looking at, you can counsel the patient accordingly and give a better prognostication at the of the procedure. So when we talk about pathogenesis and consequences, right? So these are the most common types of strictures that we are talking about. The causes of strictures. We have the radioiodine, seobrine, JRP. your oral submucous fibrosis, especially in India, and your iatrogenic causes. We also have the traumatic causes, but I've not tried to include it in this lecture. Now, the first three are basically issues which are systemic in origin, and they start to affect the duct from proximal to distal. So you have to realize that your conventional techniques of just doing a steroid flush, just doing a papillary dilatation, are really not going to affect the outcome too much in these patients, since the problem is right at the back. When it comes to oral submucous fibrosis, the problems are, as we all know, at the papillary junction or the distal segment, and these are quite amenable to treatment. However, the papillae can be quite difficult to identify in such cases. So, what's the role of sialendoscopy in all these conditions? Number one, making a diagnosis. Every patient does not have access to a MR sialography, a good center. Of course, MR sialography, at least in our center, is quite expensive, and the charges are almost as much as a diagnostic sialendoscopy. So we prefer to do an endoscopic examination. It's a valuable prognostication tool. Apart from that, in the treatment aspect, it's a good tool to flush out any mucus plugs or debris which are present deep inside the gland, which can act as nidus for infection. It is a delivery system for medications like steroids. And of course, at the last, but definitely not the least, we have the mechanical dilatation effect of the endoscope itself. And we can stent under visualization. Now, the rationale for dilatation is really, really quite simple. So, we have our gland with its rate of flow, right? And this rate of flow is directly proportional to the fourth power of the radius of the duct, just to simplify things. So, even if we are able to achieve, let's say, zero point 0.1 millimeter of dilatation with our endoscope, and we're talking about a duct which is almost 2 millimeter. So we have a lot of increased in salivation and lesser chances of obstruction. So whatever you do, whatever little you do, it will always translate to a symptomatic relief for the patient. How long? That depends on what technique. So we have our types of dilatation. We have a balloon-assisted dilatations. We have a serial dilatation by forcing the endoscope through the strictures. We have a micro-incision techniques. We have a bougies, and most importantly, we have a stents to preserve that dilatation which we've achieved through our various techniques. And we shall be discussing these. So I remember the last lecture, someone had asked me about the endoscopes. So this is an all-in-one endoscope. It is an integrated system with 3 ports, as you can see right here. The bottom one is fixed with the optical fiber, and this is a non-removable part. The upper part, where there will be a water sign, is usually where your irrigation channel goes in, and you use a lower log syringe to attach to that. And the middle one is the widest, and that's your instrumentation port. In this, you can see the basket being already deployed. And they come in various sizes. We have a 0.9, 1.1, 1.3, and 1.6. Now remember, the zero point 0.9 millimeter scope is just a diagnostic scope, and it does not have an instrumentation channel. We next have the modular system. Now, the modular system, the endoscope just looks like this. It's just a naked optical fiber right here. Why is it modular? Because this optical fiber can then go into various sheets. These sheets come in varying diameters. So there's just one endoscope which is used for multiple diameters of sheets. So this is an examination sheet. When you see this port, that's where your irrigation goes in, and your optical fiber slides right in. This is a diagnostic sheet, so there's no port for instrumentation. But this is quite thin. They come in as lower diameter as 1.1, and they can go up to 1.8. So you can use multiple sheets according to your preference. Now, this is an intervention sheet where the bottom one is, of course, for your endoscope. So your endoscope optical fiber goes in, and your top one is where your instruments go in. I would like you to notice that the end of this scope is beveled in nature. So with a beveled endoscope, it is easier to dilate a stricture dilate a stenosis. But at the same time, with this bevel comes the danger of perforating the duct as well. So you really have to be careful what you're doing. So, what endoscope to use would be one of the questions, and I thought I'll answer that. In my opinion, for a stenosis case or a diagnostic case where we're not dealing with a stone, the modular scope would be slightly more suitable. Various reasons for that is number one scope, you're putting only one scope at risk for various diameters of the sheets. It's more sturdy than the all-in-one scopes, and the optics are less easily damaged. We have the beveled edge, as I've already mentioned. And this can be pre-bent to reach tertiary branches where the all-in-one scope, you can't really take the liberty of bending it too much. We have our additional helpful instruments when we're talking about stenosis. Number one would be the guide wire. It's always advisable that you dilate your strictures over a guide wire so that you can see what's going on and where you're going. The second would be a bougies, and that's a picture right here, right at the bottom. If you could see, there's just a hollow metallic tube with a conical tapered end, and it's hollow, so it can really slide over your guide wires and achieve that dilation effect. Of course, there's a drawback of it being a blind procedure, but yes. The same things comes in a flexible system as well, where there's a lesser chance of a traumatic injury to the duct. We have our balloons. We have a microburr, which is right here. We have our laser systems. However, I have not used laser for a stenosis case, which I shall be coming to about my personal reasons why. We have ultrasound as an intraoperative tool. Now, suppose there's a complete stenosis or a really, really narrow stenosis, let's say 90% stenosis of the duct. Sometimes with your ultrasound done side by side, you can advance your scope, not seeing the lumen of the scope, and just tracking it with the ultrasound. And this is something really magical that I saw in Langen. I've not had the guts to do it so far myself, but it's really, really fascinating the way they were able to achieve dilation of almost a complete stenosis of the duct. And of course, at the end of the procedure, stents, they are invaluable when we're dealing with strictures. Now, coming to some case studies. Now, for a papillary stenosis, for a submandibular duct, it's quite easy. And some of you might remember this video from the last one. It's where the papilla, you cannot enter, and the entire problem originates right here. So for that, we give a small incision between um, the tongue base, the floor of the mouth mucosa and the sublingual crest. And we dissect in an avascular plane. You can see the duct coming up right here. Once you've identified the duct, you take a couple of stay sutures just to secure the duct in place. You can proceed with, and you give an incision over the duct right here. Once you've opened up the duct right here, you can proceed with your sialendoscopy. And at the end of the procedure, the age-old thing of just marsupializing the duct right here works wonderfully well for submandibular papillary stenosis. When we talk about parotid papillary stenosis, the situation becomes slightly more complex. Now, this is a case with oral submucous fibrosis as well. And the papilla was really, really identified with uh, uh, with quite difficulty. But you can see a drop of saliva which is being expressed right there. And that is how you deal with a papillary stenosis. Now, coming to a case study, now let's talk about a filiform or a very, very web-like stenosis. This is a parotid duct. I want you to notice the ductal walls as well. Now, you have a normal vascular markings of the duct in a normal patient. And these will generally be preserved when we're talking about an inflammatory or a web-like stricture. You can see the web strictures on your right. We are trying to advance the scope with much difficulty, and you'll be able to see the web-like strictures right here, and you can see a lot of mucus plugs that go along with that. So on your right would be the web, and you can see the web right there. Now, Well, at first look, you would assume that the patient duct is absolutely fine, but we got an MR sialography for this patient, and believe it or not, there were um, localized salivary collection seen on the MRI, which gives us the indication. Now, in this case, I'm using the micro burr to basically shave off the web-like thing. When this doesn't work, you can also incise it like a myringoplasty. So this is where we are trying to perforate the web-like structure, and you can see, and basically you try to go all around it. You go around it, making multiple puncture marks and then trying to join them together. Now this tends to increase the diameter by quite a lot, and once you've increased your diameter, you know that your problems are going to get resolved for quite a long period of time. At the end of the procedure, you can see that we have a nice dilated duct at the end of it, and the patient is doing quite well now. You can see the final diameter where your web has almost been completely excised. Now, coming to the more complicated, we have our S2 stricture or your mid-ductal stenosis, which is of a short segment. And this is a video where you can really barely see the lumen of the duct. It's in these type of ducts, you have your fibrous elements. Fibrous elements are depicted by loss of vascular markings. Your duct will look pale or whitish. In this case, it's looking whitish. And you basically, in this, I'm trying to force my endoscope right through. I'm using the 1.6 millimeter diameter Sialendoscope for this procedure. And you can see I'm really trying to negotiate the duct without going outside the duct. Constant irrigation is maintained so as to keep the lumen visible, because once you lose the lumen, you can really cause all sorts of problems. We go proximally and we see some element of pinkish change of the mucosa, which appears to be quite encouraging. But we then encounter a second stenotic segment right here, which is then negotiated as well. And this is quite a tight stricture. You can see the endoscope advancing. And yeah, and that's a duct beyond the tight stricture. Once you get past this stricture, you'll suddenly see that we have entered a nice wide area of the duct, and the mucosa is pink again. You can see your vascular markings, and you can really advance without difficulty. So once you've achieved that, you've done almost a complete job, and you just dent the area of the duct which was diseased. I prefer to use to leave the stents for quite a long period of time, and I might have to change them in the interim period. But I feel more secure in the knowledge that prolonged stenting is going to translate directly into a prolonged treatment resolution. So you can see on the top half of your screen that much of mucosa has been scraped without causing a perforation. So there's a ground glass appearance of your duct right there where your trauma from your dilatation. But if you stent it for 6 weeks, it heals quite nicely without a scar. Now coming to your S3 stricture, which is quite tough and not very favorable. So you see a progressively whiter mucosa right here. Now, once you start to go proximally, this was done over a guide wire, because it was, in this, I'm using a 1.3 millimeter endoscope, and even the 1.3 millimeter endoscope is really, I'm able to pass with a lot of difficulty. And this is the distal segment of the duct when you can barely see the lumen right here. But because of the guide wire and its bright green color, that gives you a sort of a valuable safeguard about you staying within the duct. So there's a lot of struggle which has to be done, but once you start getting a little more proximal, you see that the lumen almost disappears with every movement that you make. Eventually, sometimes you have to use uh, your guide wire as your sole indicator of where you're going. And you can really see there's a lot of struggle in stenosis, and this is something which is only done for very this is quite an advanced disease. So once we reach the hilar area, then you see the sudden dilated segment post the hilum and your branches as well. Once you reach this area, you know you're good because you've reached your hilum and your S3 stricture has been negotiated. Once you do that, of course, you give your steroid wash, you do your stenting, and you do everything, and usually the patients respond quite well. Now we are able to see the tertiary branches as well, which appear almost all right. And these are your fourth level branches. And it's only when you're withdrawing the endoscope that's the time you can really make out what you have achieved so far, as in the like the previous case. And this is me withdrawing the endoscope, and you can really see the whitish change of the mucosa. You can see your trauma because of your forced dilatation. I'm sorry about the bubbles, but that's because we like to flush the steroids throughout the ductal system, and you can appreciate that subtle change in the mucosal color. Now it's absolutely white, and that's it. So, lastly, I have a video about your iatrogenic stenosis. Iatrogenic stenosis can be because of previous surgery. It can be because of any facelift incisions, your plastic surgery procedures. You have a variety of procedures which can cause iatrogenic. This is a video where it's an iatrogenic injury by myself, in the sense that this was a laser sialolithiasis case, and laser does induce a lot of ductal fibrosis as well. So this is us dilatation, and this is what uh, after dilatation of laser stenosis, what it looks like. You see a lot of mucus plugs right there, and once you withdraw, and that's your stricture, and which is what we had dilated over a guide wire. Now this, I'm using quite a big endoscope. I was using a 2.3 millimeter endoscope. So if a 2.3 millimeter endoscope can really go in through your stricture, you're generally good. Of course, you do a check after some time as well, because you have a late stage stenosis with laser cases. When we come to the complications of stenosis, the number one, the most important one is a false passage, because you really have to continuously use strength and pressure to dilate these segments, and there's a high chance of a false passage. You have to realize that your duct is just a cell layer thick, and it really doesn't. It all it takes is one sudden movement or something with force which is not in the correct axis, and you have a false passage, and you might have to abandon your procedure. We have a higher rate of a duct avulsion as well, because one, you have to make multiple passes with your endoscope, and secondly, because of the excessive strength which is sometimes required. We have broken tips of burr or guide wires which could be inside. We have rates of race stenosis. Of course, there are strategies to combat that. And we should always remember that sometimes, I should edit it, most of the time there's not a permanent cure. It will require relooks. The patient will have recurrences, because sometimes it is just a part of a systemic disorder. And basically, what you're doing is providing symptomatic relief. Now, for your combined approach methods, you do for your distal one third of your duct, and this applies to both the parotid distal one third and, of course, the distal two-third of your submandibular duct. You have your mass utilization techniques, which work really quite well. In the literature, there's a lot of talk about interposition vein grafts. I personally have just done two so far, and both for traumatic injuries of the Stenson's duct. And all in all, they work quite well. But of course, I need more experience before I can really comment upon the absolute rates of success with that. We have our alternative therapies or strategies. Now, this slide is something that I'm going to take a little bit of time. We have a prolonged stenting. I prefer to, for a parotid duct, I prefer to stent for minimum of 3 months. We might have to change the stent in between, but the longer, what I feel is the longer we stent the duct, the better the results are. And personal experience has shown that. Now, I personally like to do a stent up method for a dilatation as well. Let's say a patient has undergone an endoscopic dilatation, comes back a year afterwards, and you try to put in your endoscope and it really doesn't go in. So, with your stent up method, you can start with a smaller French diameter stent, and we have seen that the duct dilates till about 1 or 2 French more than the stent which is kept inside. So we keep upgrading the stent. We have done cases where initially just a three French stent could go in, and over a period of 6 weeks, we put in a size 8 French. Now that really provides quite a good dilatation, and this is just from personal experience. There's no literature supporting this, but it seemed to work quite well. We have a cortisone installation, which is basically a method which is followed by the Italians, wherein after your dilatation, after your stent removal, for 6 weeks, they give cortisone installation within the duct. Now, this is thought to reduce the amount of ductal edema, or ductal inflammation, and because of your effects of your anti-inflammatory effects of your steroid within the gland, it is supposed to prevent re-stenosis. However, there's still a lot of concluding evidence which is not out there yet, but it really helps at times. Now, second last, there is another thing that we've been trying out recently, which is called an interval sialendoscopy, which we plan to publish as well. Sometimes we have, especially in our S3 and S4 strictures, we have cases where a smallest endoscope won't really go in. When it doesn't really go in, there's a higher chance of a false passage. There's a higher chance of you causing a complication than gaining anything. Now, in the interval silentoscopy, what we have started doing is, without putting the endoscope, we try to put in just a 2 French, and 2 French is just 0.6 millimeter, just a stent inside for a couple of weeks. Once you do that, with that theoretical dilatation of your duct, you get an additional half millimeter or 1 millimeter space to work with when you actually decide to do your endoscopy. That improves the results, improves your visualization, improves a lot of things. So we are going to write a paper on that. So that's something I just thought I'll mention. And of course, we have our state endoscopies. Now, this is widely recommended in literature. And this basically has formed the basis for our interval silentoscopy. In this stage, it is dilate as much as feasible, or until you have a complication, stent the duct, come out, and come back 2-3 weeks later and try to advance to a more proximal position. So these are alternative therapies. Now, let's talk about a difficult situation. Let's say the investigation of choice, whatever you've gotten done, you've gotten your MRI, you've gotten your sialography if you really feel the need. Now, that's come out to be normal. Your diagnostic endoscopy has come out to be normal. However, the patient continues to have symptoms. Now, what to do? So, these are typically the difficult situations where the results can be very, very variable. But what are the common causes? And we had to go back to the drawing board, so as to speak, to really think about what was going on in such patients. What has been postulated and really seen in personal experience as well, that there are some structural problems which may lead to malfunctioning or a wrong orientation of your ducts. Of course, you should always go back and rule out your extraductal compression. There might be small tumors, there might be small inflammatory your lymph nodes and all that, which might be causing an external compression. But more importantly, we have a temporomandibular joint disorders, your bruxism, your muscle spasm, especially the temporalis or your masseter spasms. And these can give rise to episodic obstruction of, especially of Stenson's duct, which can cause sialadenitis, mimic your mealtime syndrome, and confuse everyone, including the patient and the treating physician. Now, these are things that you really, really look back in retrospect. And these are things, unless the history is clearly elucidated by the patient in the first thing. So, Bruxism, of course, should be looked at because once you're doing an examination of your oral cavity, you should look for signs of wear and tear of your teeth, which are signs of bruxism. You can observe the patient for a longer period of time and observe him grinding the teeth, and these are important as well. For a skeletal malformation, of course, you have your retrognathia, your hypoplastic maxilla, which can preclude to salivary gland, but of course, these are more evident on seeing on a clinical examination. Now, what can you do? You have your dental appliances, you can have your muscle relaxant. Sometimes Botox injected within the offending spasm muscle can alleviate the symptoms. Of course, it's a temporary measure, but yes, and behavioral changes always goes a long way. Let's say nothing works and you've tried to identify everything, you have your denervation techniques, you have your Botox into the salivary gland. Now, we've done this for quite a few patients and we've got mixed results. We've done this in 7 patients. We've achieved success in 5. 2 had to undergo a parodontectomy. Um, but Botox seems to be a good first line option when you're considering denervation of a salivary gland, of a symptomatic parotid gland. For the submandibular, the decision is easy because you can always go ahead with the gland excision. The other techniques is a tympanic neurectomy, which I personally have not resorted to so far. And you also have a distal duct ligation. Now, we all have had experience in oncology, wherein in a lot of procedures of carcinoma buccal cavity, we've identified the stencil duct and actively ligated it. And we know the patient do not usually have symptoms. There are some patients who will remain symptomatic, but usually it works quite well by causing pressure atrophy of the salivary acini. In extreme cases, you can give low dose radiotherapy as well to deaden the acini and reduce the salivary secretions. Once the secretions go completely off, the patient's symptoms usually subside. Of course, this seems a more drastic option, and but it's mentioned in literature. As a last resort, you do have the option of a gland extirpation. However, for the submandibular, the results are quite good. The chances of a neural injury are quite low in experienced hands. But for the parotid, doing a gland excision, and we're talking about both the superficial as well as the deep lobes for an inflammatory condition. In an inflammatory condition, you're not going to get any planes. Your facial nerve will be at a much higher risk than a benign tumor, which we all are accustomed to doing parotidectomy for. And doing a deep lobe parotid excision, we all know that 80% of the secretions of the parotid gland are from the deep lobe. So that you really have to do a complete gland resection to make the patient asymptomatic. And once you do so, you have your cosmetic issues to worry about. So, personal results, submandibular strictures are, of course, quite rare. Mostly, they are sialolithiasis. I've just seen 3 in my practice. All have been successfully resolved, not had to do a gland excision for anyone because marsupialization or stenting works very, very well. In the parotid, I've divided it to your segment of the duct which is involved. Distal strictures, the incidence is slightly less and the success rate is in the high 80s. Your mid duct, you have the best success rate because that is really where you can do all your work. You can do all your dilatations, your bougies. Every instrument works in the middle duct. Proximal duct, of course, this success rate goes down because uh, these are basically the ones with your systemic conditions. And systemic conditions, one they do, these are generally progressive. And as a last thing, symptomatic patient with a normal duct, success rate remains quite low. It's just 53%. As an algorithm of how to deal with strictures, submandibular duct stenosis, we have our proximal, your intraparenchymal and your distal duct. Your distal duct, you can just go ahead with your cortisone injections or your intervention. And if it doesn't work, just do your marsupialization, you're good to go. For your proximal duct or your hilum, you have the same options. However, for difficult cases, you have your Botox or your gland excisions. And your endoscopy generally works quite well. However, gland is a completely acceptable form of treatment for these. For an intraparenchymal, the treatment becomes slightly more complex, where your interventional sialendoscopy really doesn't work quite well, especially for your diffuse stenosis. In this, all you have to be either content with your cortisone installations and hope that the symptoms subside, or you go for your gland. For your parotid duct, the treatment plan remains basically the same. And for your papilla, you have the option for your papilla or the distal one third, the one which is anterior to your masseter. You have the option for a marsupialization, failing with which you have your Botox, duct ligation, or gland removal. And for your middle or proximal, your endoscopy remains the treatment of choice. Combined approach with your vein interposition has been mentioned, but it appears to be overkill and should be reserved only for complete stenosis. And your intraparenchymal, of course, you have your cortisone injections, you have your interventional endoscopy, but these are typically the ones who don't do so well and may require a gland or a Botox or a duct ligation. Now, future research is needed in this topic because stenosis is a relatively newer condition. It's just been recognized about 15, 16 years back. So, coming back to the salivary gland function, we should uh, take that technetium scan with a lot of consideration, because you have to realize that whatever dilatation that you do, whatever dilatation that you achieve, ultimately the gland has to be functional for this to stay. If there is no saliva which is passing through whatever dilated segment, the patient is always going to have pain when there's a challenge for salivation. So the technetium protected scan becomes quite relevant when everything fails. Because in a non-functional gland, then you can consider your more radical options, because you know your endoscopy is not going to work. Of course, people are working on stem cell therapy and creating artificial glands, and that seems to be exciting for us endoscopists. And more research is needed on biostents, because whatever stents that we have right now are temporary at best, and till they are in place, the patient remains asymptomatic. But sooner or later, there could and there is a lot of recurrences, and biostents may prevent the recurrence rate. Thank you, and I'm free to answer any questions if there are any now.
Thank you, Dr. Varun. This is indeed one of the rare webinar, I think, I guess, in this series of lockdown webinars, I mean, happening throughout the world. Not much has been discussed about non-sialolithiasis endoscopy indications. I'm sure most of the participants had a lot of take-home messages today. We have a few questions. Dr. Jaisinki was asking, can you show the stenting procedure again? Please show.
Yes, okay, one sec. I'm just going to, can you give me 1 minute while I answer? If you could ask me
Yeah.
something. I just put in a wrong video, and I was supposed to show stenting.
Mhm. Okay. Meanwhile, what is the cortisone installation dose and frequency?
Okay, so frequency, what is given in literature is once a week for 6 weeks.
Hmm.
We're giving a 100 ml hydrocort injection, the pre-made vial that you get, and just instill it using a 24 gauge cannula.
So then, how do you treat parotid calculus, and how common is it?
Last lecture, someone missed the last one.
Yeah.
Okay. Okay, so parotid stone, someone who is actively doing sialendoscopy, we are going to see a lot of parotid stones as well, because those are the ones which are referred, right? So I personally have done about 65 to 70 parotid stones.
Hmm.
So, but that is in no indication of the incidence of it.
Hmm.
The worldwide literature quotes a 10 to 15% incidence of parotid stones, but of course that is skewed amongst areas where you are going to get reference.
Okay. Then Dr. Sridharan was asking, how do you detect post-operatively that you have perforated the duct in dilatation?
Okay, you are supposed to catch that intraoperatively. So I had shown this video in the last slide as well. Once you see cord-like structures through your endoscope, you see
Okay.
capillaries, and that's the time you know you have perforated the duct. And these are important things to catch immediately, because if you ignore them and you continue with your irrigation,
Hmm.
what happens is that there's a lot of fluid leak into the surrounding tissues, which can lead to quite severe infections and cellulitis.
Hmm.
So you really need to catch these immediately.
Okay. Dr. Ashok was asking, how do you prevent and manage mucosal inversion of the duct?
I didn't get that. Can you repeat that?
How do you prevent and manage mucosal inversion of the duct? Uh,
We're talking about avulsion of the duct.
I don't know. If you can read the chat area.
One sec. I'm still one sec. Okay, chat area. I think we're talking about avulsion of the duct. We're talking about the
Could be.
distal avulsion. For that, you need to have a constant check on your papilla, and of course, if you just let's say you have an avulsion, the first thing that you're going to see is your soft tissue, right, on your endoscope. The indirect sign is that the area which is surrounding the papilla will start to get ballooned up because of a saline extravasation. Now, these are clear-cut indicators that you have avulsed it up. What you have to do after that is basically do a oral cavity exploration, try to dissect and find the distal segment of the duct, and then um, either bring it forward or marsupialize it or whatever.
Dr. Vijay Victoria is asking, what about culture sensitivity and what are the common commensals and pathogens you get? What's your experience?
So I usually don't get it done, to be very honest with you, because it really doesn't matter to me, right? It's more of historical interest. What commensals, what is your this thing? Our antibiotic regimen has really remained the same. We've started out with clindamycin usually when we talk about salivary gland infections, and yeah, that's worked quite well. I personally have not gotten culture sensitivity done.
Okay. Then what is the pathognomic picture of MR sialography in Sjogren's syndrome?
The pathognomic picture is that you will be not be able to see the main duct in almost all cases, right? And you would see I have a picture. I have a picture on my slide.
Yeah. Meanwhile, the attendees can unmute themselves. If you have any question, you can directly ask the speaker.
Hello.
What is the role of sialendoscopy in Sjogren's syndrome?
As I've said, the last S3 stricture was a case of Sjogren's syndrome, right?
Hmm.
So the role of your silentoscopy is to basically dilate whatever strictures. You have to flush out all the debris, right? I'm sorry. Okay. So you flush out the debris, you dilate your strictures, and this leads to a lot of symptomatic relief in such patients. And I can't hear.
There's some audio disturbance at your end. I don't know something. Okay, it's okay. Dr. Ashok Shah was talking about the mucosal inversion. He says sometimes it occurs during removal of an intraductal stone with basket.
Oh, yes. Okay. Now I got it. So the thing is, you have to really assess the entire segment of the duct, right? Before you attempt a basket of the stone. So what happens is, let's say it's a narrow duct. Let's say the ductal diameter is 3 millimeter, and you're trying to basket a stone which is 4.5. You might be able to engage the basket, but it's going to remain stuck right there. The tendency sometimes is to be overzealous and to tug at the basket really hard. That should not be done. Once you do that, the entire duct can get avulsed from the gland, and that forms uh, a treatment dilemma. The accepted thing is you have to do a gland excision on table, right? The other option is, of course, you open up the floor of mouth posteriorly, similar to the videos that I had shown in the earlier presentation, right? And you basically repair the duct. So once you repair the duct, that's the time you can, that's how you treat such a thing.
I think we have come to the end of Q&A session. Yeah, any attendees, if you have any questions, you can unmute yourself and speak to the speaker directly. Otherwise, we can now, I think, wind up the session.
I'll just show the stenting procedure
Yeah,
once,
yeah, please go ahead.
right? I've just managed to edit it while answering the questions. Just give me a second.
Yeah, yeah, sure.
It's just getting rendered. So, is there any other doubt? This is quite a weird topic of how to depict also, because stenosis is hitherto quite new disease, right? So to depict it accurately and really depict how to treat such a thing, so it becomes slightly an issue as well. So just a second. Okay. Right. So I'll just share the screen again. Okay. So this is a video. This is the same video that I was intending to show earlier with the papillary stenosis. You can see the guide wire which is inside the duct. Hello.
Yeah, we can see it.
Okay, so I'm just going to play that. So what we do, we have those pre-made stents where a company is quite happy to make it. We load it onto a guide wire, and it's really just slid inside. You can see it sliding over the guide wire, and it goes within through the papilla, right? And you basically just slide it across, and it goes and sits inside the duct. You see the end of the stent has a phalange with multiple holes within it, where you can just use a non-absorbable suture and stitch it to the buccal mucosa for it to stay in place. So that's the stent. I hope that answers your question.
Jay Singh, I hope your query has been answered.
Yeah,
Yeah.
great.
I think we have one more question. How often have you had to convert to an open procedure or abandon the procedure, and would you give a gap before reattempting?
We're talking about stenosis or stones.
I think stenosis.
Stenosis open, it's really not required. You can always come back another day, right? As I said, there are a lot of strategies to tackle the difficult situations. In case, let's say you have a false passage, you just stent the duct. You stent the duct, you come back after 2 weeks, that area would have healed, right? And with your stent, that your duct will also be a little more dilated, so you can continue. So that is why for a stenosis, we always take consent for a staged uh, approach. Now, the open approach would have been more feasible had the stenosis been more common in submandibular glands, because then the decision is quite easy for us. But taking the difficult decision of doing a complete total paratidectomy for a stenosis, it's really a harsh decision and a tough decision for the doctor as well as the patient. So the open approach is really, really frowned upon. There's a lady who's now been under follow-up for 3 years now, but for the first year, she underwent a Sialendoscopy 26 times.
Oh,
26 times. Most of the times it was done in the OPD. But now for the last 2 years and 3 months, and she's absolutely fine. I've rechecked her duct, I think 3 months back, and it's absolutely brand new. There's no stenosis. So, you just have to persevere, persevere, persevere. And this is a parotid gland in a young lady. So these are, you know, you have to be persistent. Eventually, the results are good.
Hi, sir. This is Alex. I'm the one who asked the question. Brilliant talk. I'm from Singapore. So just to get the what you just said correctly. So if you have a stenosis and basically you are faced with a roadblock and you do not want to advance, you basically withdraw, and you said you give a gap of a couple of weeks and then go back. So am I correct in saying you know that you would likely create a stenosis because of whatever injury or damage, and then when you come back, you allow the healing, the inflammation and all that to occur, to settle, and then you treat it like a fresh stenosis again? That's number
Exactly.
one.
Yeah.
Okay. Two, as you asked at the outset, what if in the case of stones? So once again, there used to be teaching in the past wherein you do ultrasounds, you look for sludge and so on and so forth. But I'm sure in your experience as well, you would have come across situations wherein you go in and you're like, where is that stone? And where is that thing that was causing all the symptom? You don't see much. Would you
Yeah.
chase it all the way? And two, when you land up with the same complication, as I said, you'll land up with a roadblock or there is a problem. Would you again say, wait, I don't want to go further. Would I go back, not cause any more damage, do a flush, put in a stent so that nothing strictures with all the manipulation that I've done, and then go back again?
Yes. So the thing is, similarly for S3 and S4 strictures, right? What you've mentioned is exactly the kind of roadmap that you have in your mind. Your aim is to dilate whatever you can feasibly, whatever is feasible without causing any damage. If unintentionally you've caused a ductal perforation, you should immediately come out. Because in the case of a stone, you can really, really, remanipulate and try to get inside the true passage and take out your stone, because that's going to be a one-stage procedure. In a stenosis,
Right.
things can get exacerbated because your perforation is going to heal with a lot of scarring
Right.
initially, which is going to cause stenosis and which may lead to further being a lot more problematic than what it was in the first case. So I would stent immediately, make sure the stent has not gone outside ductal perforation, and come back another day, right? I
Okay.
hope that answers your first question.
Yep.
Uh, for the second one, for those invisible stones, where you see, you get a CT done and you see a stone which is there, and you do your silendoscopy, you don't see anything. And I have the unfortunate or the dubious distinction that this happened to me when I was operating live at a conference.
Oh,
Yeah, so this was supposed to be a 3.5 millimeter stone, and we did our silendoscopy. We went through each and every duct. We really explored whatever was feasible at that point of time. Used the smallest endoscope, still couldn't find it. That point of time we employed, and what we usually do now is do an intra ultrasound as well. Try to localize the stone with the ultrasound,
right.
right? That works wonderfully well when the stone has, let's say, been pushed towards your gland.
Okay.
let's say this stone has shifted into one of the Bartholin duct, your supplement,
After you finish
it
it,
doesn't catch it too well.
I will clear
In
up.
those cases, sometimes we've also had to use the C-arm to try and localize, then do a floor mount dissection right there. So there are multiple ways of how to get the stone out.
Okay.
So it really depends. Uh, there are patients where we've not found anything, and at the end of the procedure, if I have not found what I was looking for, I would definitely stent the duct and then come out.
Right. Okay.
Has the effect of dilating the duct, right?
Yep.
And keeping the papilla wide open as well. In
Right.
the
Okay.
post-operative period, when you're taking out the stent, the stone might just get flushed out.
Right. Right.
Yeah.
Okay.
Uh,
Brilliant.
Dr. Varun?
Hi, ma'am. How are you?
Yes, I'm very well. Thank you. Thank you for a most informative talk. I'm really enjoying your sessions.
Thank you.
I just wanted to ask you a question. If there is a stenosis that you're dilated, say today, next when would your dilation be?
Ma'am, it depends on the type of stenosis. If I'm dealing with a fibrous stenosis, I would wait for a couple of weeks.
Okay.
If I'm dealing with an inflammatory stenosis, I can do it as early as next week, 7 days. It really depends on patient to patient, and in the interim period, I would definitely leave a stent in. So it's a very dynamic situation. I'm not followed a particular protocol. Leave it up to the patients with their comfort zone as well.
So in tracheal stenosis, once in 3 weeks we will take up the patient. So there's nothing like that for.
Ma'am, for me, because I'm doing most of these cases under local in the OPD,
Okay.
so I don't need the OT time, and the patient does not have to bear a huge cost every time as well. So I leave it up there. Just schedule it as a regular OPD visit with keeping the rest of the appointments free for the next half an hour. That's it.
Okay. And the next question is, if we have to use multiple stents in one patient, so how much do these stents cost?
Ma'am, the stents which I have been using for the last 2.5 years, they're made by a wonderful guy in Bangalore.
Okay.
And, they cost 1,200 rupees, so they're not
Oh,
too
that's all.
expensive.
Okay. Okay.
Yes.
Thank you, Varun. Thank you.
Thank you, ma'am. Pleasure.
Hello.
Yes. Hi, sir.
Hello.
Hi, sir. Yes, sir. I can hear you, sir.
What type of anesthesia would you prefer for these cases which we are doing stenting and all that?
Local anesthesia, sir.
Local anesthesia. And in children, suppose, especially Jogren syndrome and all that?
So in children, definitely because of logistical reasons, you have to do it under general anesthesia.
Okay.
And thankfully, the condition which is most prevalent in children is juvenile recurrent parotitis.
Yeah.
The juvenile recurrent parotitis, in just one sitting of sialendoscopy, has an almost 83% resolution rate.
Wow.
Right? So once we have those figures, and we know it's a self-limiting condition, thankfully we don't have to put the child under anesthesia over and over again.
Yeah. Yeah.
Yes, sir.
That's correct. Thank you.
Thank you, sir. Thank you.
I think we have all the questions have been clarified.
Great.
Yeah.
Right.
Thank you. Thank you, Dr. Varun, for accepting our invitation to a two-part webinar series. It was really indeed a great lectures in both the two sessions. We hope to have some more webinars with you in future. And with this, I would like to thank all the audience who have been here with us for the past 1 hour 15 minutes. With this, sir, any closing remarks from you?
So I would just like to thank you guys. You've been wonderful, and you are doing a great job with all these webinars and spreading awareness and knowledge from really great people who I know have been there on your forum earlier as well. It's really nice and it's really informative. And this is, I mean, I think as a community we should take forward and continue this even post lockdown era. So I
Yeah,
hope that.
definitely. With all the support of all the speakers and audience, we would definitely would like to continue and go ahead. Thank you once again, and with this, have a good night.
Thank you.
Thank you, sir. Thank you.
Good night, sir.